For the compliance committee, we're going to be meeting. Dr. Bechtel will be calling us to order after we're done with
This conference will now be recorded.
I apologize that the go-to meetings lady interrupted you, Ms. Montgomery, but we are live streaming now and we're ready to begin.
I think we'll go ahead and proceed with the meeting, and I'd like to have Ms. Marshall proceed with the settlement agreements, please.
Yes, we have our first settlement agreement, DHMD.
Do I hear a motion to ratify the proposed consent agreement for DHMD? Do I have a motion?
So moved.
Dr. Soin, a second?
Second, Dr. Cockrell.
Now we'll take a roll call vote. Dr. Rothermill? Not present. Dr. Safran?
Abstain.
Mr. Gaccalone?
This is for DHMD, correct?
That is correct, sir.
Okay. No.
Dr. Soin?
No.
Dr. Schottenstein?
No.
Dr. Reddy?
No.
Dr. Johnson?
No.
Dr. Coccarella?
No.
Mr. Ganadakis?
No.
Ms. Montgomery?
No.
Dr. Feibel?
No.
And myself, Dr. Bechtel, no. You can proceed, Ms. Montgomery? Or do I have a motion to ratify the proposed permanent surrender of GDJGMD? Do I have a motion?
So moved, Dr. Johnson.
Dr. Johnson, thank you. Second?
Second, Dr. Cockrell.
Thank you, Dr. Cockrell. Roll call vote, Dr. Rothermill. So, Dr. Rothermill has arrived. I'll go back to her in just a second. Dr. Safran?
Abstain.
Mr. Gaccalone?
Yes.
Dr. Soin?
Yes.
Dr. Schottenstein?
Yes.
Dr. Reddy?
Yes.
Dr. Johnson?
Yes.
Dr. Coccarella?
Yes.
Mr. Ganadakis?
Yes.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
Dr. Rothermill,
Yes.
we're voting on GDJGMD.
Yes.
Okay.
Abstain.
Abstain on this. Very good. And myself, Dr. Bechtel, abstain. We'll now go to the IED RCP. Do I hear a motion to ratify the proposed consent loan agreement for IED RCP? Do I have a motion?
So moved, Dr. Cockrell.
A second?
Second.
Roll call vote, Dr. Rothermill,
Abstain.
Dr. Safran,
Abstain.
thank you. Mr. Gaccalone,
Yes.
thank you. Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Coccarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
and myself, Dr. Bechtel, yes. Now we'll turn to the matter of JBDMD. Hear a motion to ratify the proposed Step 2 consent agreement for JBDMD. Do I have a motion?
So moved, Dr. Johnson.
Thank you, Dr. Johnson. The second?
Second, Dr. Cockrell.
Dr. Coccarella. Roll call vote, Dr. Rothermill,
Abstain.
Dr. Safran,
Abstain.
Mr. Gaccalone,
Yes.
Dr. Swain,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Coccarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
and myself, Dr. Bechtel, yes. We'll now turn to the matter of KMR PA. Do I motion to ratify the proposed step 2 consent agreement with KMRPA? Motion, please.
So moved, Dr. Johnson.
Thank you, Dr. Johnson. Second.
Second.
Second, Dr. Thank you, sir. Roll call vote, Dr. Rothermel,
Abstain.
Dr. Safran,
Same.
Mr. Gacaloni,
Yes.
Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
myself, Dr. Bechtel, yes. We'll now turn to the matter of MAHMT. Do I motion to ratify the proposed step 1 consent agreement with MAHMT? A motion, please.
So moved, Dr. Johnson.
Thank you, Dr. Johnson. A second.
Second, Dr. Caprella.
Thank you, Dr. Cockrell. So roll call vote, Dr. Rothermel,
Abstain. Excuse me.
Dr. Safran,
Abstain.
Mr. Gacaloni,
Yes.
Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis.
Yes.
Thank you, sir. Ms. Montgomery,
Yes.
thank you. Dr. Feibel,
Yes.
and myself, Dr. Bechtel, abstain. We'll now turn to the matter of MHA-MD. Do I motion to ratify the proposed permanent surrender retirement with MHA-MD? Do I have a motion?
So moved, Dr. Johnson.
Thank you, Dr. Johnson. A second.
Second, Dr. Caprella.
Roll call vote, Dr. Rothermel,
Abstain.
Dr. Safran,
Abstain.
Mr. Gacaloni,
Yes.
Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
and myself, Dr. Bechtel, yes. We'll now turn to the matter of RGRMD. Do I hear a motion to ratify the proposed permanent surrender with RGRMD? Do I have a motion?
So moved, Dr. Johnson.
Dr. Johnson, thank you. A second.
Second, Dr. Caprella.
Roll call vote, Dr. Rothermel,
Abstain.
Dr. Safran,
Same.
Mr. Gacaloni,
Yes.
Dr. Soin,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
thank you. Dr. Cacarella,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
myself, Dr. Bechtel, abstain. We'll now go to Ms. Marshall, who will present the proposed citations to the board. Ms. Marshall.
President Bechtel, members of the board, thank you. We have 7 proposed citations for you this month, 3 of which are summary suspensions. Our first cite, which is a summary suspension, is to be issued to a licensed massage therapist. It is based on failure to submit to a board-ordered chemical dependency evaluation based on her history of 2 OVI convictions and her departure of 2 prior treatment programs without completion. Our second citation is to be issued to an MD. It is a proposed denial for MD licensure here in Ohio based on a history of 2019 felony convictions related to practice for unlawful distribution of controlled substances. There's also a credentials aspect to this in the fact that the physician has had no clinical practice since 2018. Citation number 3 is a summary suspension. This is based on an expert forensic report we recently received from a board-ordered psychiatric evaluation that opined that this physician is unable to practice at this time due to unspecified neurocognitive disorder. Our fourth citation is to be issued to a respiratory care professional. This is a restoration applicant with a history of license revocation by the California Respiratory Care Board in 2012 related to substandard care involving several patients. Citation number 5 is to be issued to an MD. This is based on action by the Arizona Medical Board that arose from a guilty plea to attempted sexual abuse of a patient. This physician's Ohio license lapsed in 1992, therefore it doesn't trigger an automatic suspension. But given the nature of the offenses, we wanted to make sure to cite this so we can deal with the licensure aspect here. Citation number 6 is to be issued to an MD. It's based on action by the Michigan Medical Board related to pending sexual assault charges. Citation number 7 is another summary suspension. It is based on a first relapse on alcohol. That is all of our citations for your consideration. Thank you.
Thank you, Ms. Marshall. Do I hear a motion to approve and issue citation number 1, a summary suspension? Do I have a motion?
So moved.
Dr. Swain in the second, Dr. Coccarella. Roll call vote, Dr. Rothermel. Dr. Safran.
Abstain.
Mr. Gacalone.
Yes.
Dr. Stein.
Yes.
Dr. Schottenstein.
Yes.
Dr. Reddy.
Yes.
Dr. Johnson.
Yes.
Dr. Coccarella.
Yes.
Mr. Ganadakis.
Yes.
Ms. Montgomery.
Yes.
Dr. Feibel.
Yes.
And myself, Dr. Bechtel, yes. Do I hear a motion to approve and issue citation number 3, a summary suspension? Do I have a motion?
So moved, Dr. Johnson.
Thank you, Dr. Johnson. A second?
A second, Dr. Cockrell.
Roll call vote. Dr. Rothermel.
Abstain.
Dr. Safran.
Abstain.
Mr. Gacalone.
Yes.
Mr. Gacalone. Sorry.
Yes.
Okay. Thank you, sir. Dr. Soin.
Yes.
Dr. Schottenstein.
Yes.
Dr. Reddy.
Yes.
Dr. Johnson.
Yes.
Dr. Coccarella.
Yes.
Mr. Ganadakis.
Yes.
Ms. Montgomery.
Yes.
Dr. Feibel.
Yes.
And myself, Dr. Bechtel, abstain. Would any board member like to consider any other citations separately? If not, we'll go forward. Do I hear a motion to approve and issue citation number 7, which is a summary suspension? Do I have a motion?
So moved, Dr. Johnson.
Thank you, Dr. Johnson. A second?
Second, Dr. Cockrell.
Thank you. Roll call vote. Dr. Rothermel.
Abstain.
Dr. Safran.
Abstain.
Mr. Gacalone.
Yes.
Dr. Soin.
Yes.
Dr. Schottenstein.
Yes.
Dr. Reddy.
Yes.
Dr. Johnson.
Yes.
Thank you. Dr. Coccarella.
Yes.
Thank you. Mr. Ganadakis.
Yes, sir.
Thank you. Ms. Montgomery.
Yes.
Thank you. And Dr. Feibel.
Yes.
And myself, Dr. Bechtel, yes. Do I hear a motion to approve and issue citations 2, 4, and 6? Do I have a motion?
So moved, Dr. Johnson.
Dr. Johnson, Dr. Coccarella, thank you. Roll call vote, Dr. Rothermel,
Abstain.
Dr. Safran,
Abstain.
Mr. Gacalone,
Yes.
Dr. Soin,
Yes.
thank you. Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Coccarello,
Yes.
Mr. Ganadakis.
Yes.
Thank you. Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
and myself, Dr. Bechtel, yes. We'll now turn to our operations report. Ms. Stephanie Luca, our Executive Director, will now present the operations report. Ms. Luca?
Thank you, Dr. Bechtel. Good afternoon, board members. Your operations report is broken down per usual. Of note in our human resources activity, we are busy backfilling some positions, as well as, just kind of continuing through the hiring process. Of note, I think from what I would put in the HR bucket this month, our senior leadership team has been participating in a communication strategy course, for lack of a better word. It's called DISC. It's something that's been offered to us by the Department of Administrative Services. It's really a sort of measure of how we behave in certain situations, in certain work situations, and then working with each other based on our behavioral response types. Frankly, just to better understand each other, to better be able to communicate, I think understand motivation, understand work habits and that sort of thing. So certainly over the last year, working remotely from a leadership team has been challenging. I'm obviously newer to the board. We have new staff members as well. So I'm loath to squeeze any more time out of our exec staff folks, given their busy schedules, but I thought it was important that we sort of engage in this activity. And I do think they found it helpful. I'm hearing folks still talk about it, and we'll continue to build on that over a series of a couple more meetings into March and April. It's really a communication and behavioral style sort of thing. And then I can't remember exactly what DISC stands for, but there are 4 different behavioral types. And we are sort of across the map with what our behavioral types are. So that's good. We have some balance, but return to work planning, we're still engaging in discussions about that. Some of that will probably be dependent on what the state bargains with the major union contracts. We have not received word as to how that bargaining is going. We're still heading toward our goal of some folks staying at home 100%, some being hybrid, and some being back in the office full time. So I would love to have told you that we had a better update for you at this time, but we don't yet, nor do we have a return date given to us yet from the state. Budget update, Dr. Schottenstein will go into this in a little more detail, but our revenue is certainly not looking as healthy as we would have expected, given that many of our licensees are still delaying their renewals. Given that license renewal extension, we have about, I think, 14,000, little under 14,000 that still need to renew by July 1st. So we're seeing that in our revenue. We fully expect that to catch up with us, and we should be in a really healthy revenue state at the end of the fiscal year. We have started communications with those licensees to remind them that they need to start renewing, and that date is coming. That was really effective for us in the fall with getting folks started back on the process. So we're hoping that we have that same success this spring. We're also hoping that this does not get extended again. I do not think that it will. I will be very surprised if that got extended again. I included for you this time, and I will not go into detail on this. I included for you some work group updates in the operations report. I thought it was important. We sort of drive so much of our work toward the board schedule, and so much of what we do is based on building the agenda for the next month. I thought this was a nice sort of glimpse behind the curtain on some of the other things that are going on at the board, just so you can see some of the other activity. This is certainly not exhaustive, but just, kind of gives you a little update on each of the work groups. I think probably of note, and Chelsea, you'll hear from Chelsea later in the legislative affairs update, but Chelsea and I have been increasing our visits with legislators as we shop our budget and start to talk to them about our priorities. You can see sort of all of the different meetings that we've had there. And then with respect to licensure, I'll just point out again that the licensure staff has just done an absolutely terrific job at home, keeping things on staff or keeping things on track and doing things really well. So I did also want to take this time, in the state, we can't randomly give out bonuses or raises for people when they do a really good job. We can give them public acknowledgement. So we received an email about one of our licensee staff members last week. It's for Brianna Williams. And this is the message we received. It said, after having a difficult time with the website, I finally found a phone number so I could talk to a real person. Thankfully, Brianna Williams responded to my call. She was extremely helpful and accurate in her advice to me. She was also very patient with a computer moron like myself. She has restored my faith in humanity. She deserves a big fat raise in her paycheck and should be put in mass production. I have several boards about my license, and she is by far the best advisor I have had. So that's enough detail on that. But I thought it was just a really great email. Those are the kind of random moments we like to hear about because they're working hard and sometimes dealing with folks who are in a really frustrating situation, as I'm sure as licensees you all can attest to, or licensees of other boards. Our open complaints and closed complaints dashboards, there's nothing really to significant to note from last month with those. I would say, our complaints continue to increase. You can kind of see the trend lines for yourself. There's really nothing significant over last month that we've noted there. We are really actively engaged in our work with enforcement on complaint management, with having James in his new role as the chief of complaint management. And so we're hoping that will help us address kind of this, how much water we're taking on the ship over time. So that's all for my operations report. I'm happy to answer any questions. Oh, I'm sorry. One last thing. There's information about the FSMB meeting in the back. It will be a virtual meeting this year. If you would like to register and you did not receive registration information you should have from FSMB, I'm happy to send that on. Please just let me know.
And I just have a question.
Sure.
Why did we have such a big jump in complaints? Or if you look at legal, I have sometimes a hard time, as you know, with your charts, but we had a big jump in August and then a decrease in January. Is there any explanation to that?
I'm sorry, what page are you on? They're numbered for you.
Yeah. It's your mystery. It's the I believe it's the open complaints dashboard. That would be page 345. I don't know. I can just ask you offline. That's not, I just was curious what caused it.
Okay.
And the other thing is that it would be really nice to know, and maybe it's in your charts and I just can't tickle it out, which would not be a surprise, that the percentage of cases that we're getting are standards versus, that the board is getting standards versus bootstrap. So we can decide, and then how that compares to the complaints that come in. So we could get a sense of, are we handling the priorities the right way? Is that in the chart? I just haven't tickled it out.
So I think we do have it based on board action at the bottom, but to your point, I think we don't have good data and good explanations on the prioritization yet, but it is something that we're specifically looking at over the next, I would say 3 to 6 months. We should be looking at and coming up with solutions for how things come in the door and then how they get assigned to whatever group they're going to, whether it's investigation standards or enforcement.
Well, it's all about bootstraps are really important. And of course, sometimes we had one bootstrap that comes to us, today. I think it's 20 years old, right? So they're important, but obviously meeting standard of care and sexual stuff are more important, or certainly to prevent continued damage. And so I just thought it was important for us to try to tickle that information out however you can.
Mm-hmm. We do have a system of prioritization today. I think what we can probably say is that the system that we had in place isn't keeping up with the volume of cases that we're receiving. And so to your point, that's exactly right. We need to look at those different buckets and say, how do we assess those, given our staffing, given our tools, how do we assess those priorities?
And I have one other thing, Stephanie. I just want to do a shout out to you for anybody who watched Stephanie's presentation for the budget. She did a great job. It also doesn't hurt to be the last on in a long day. You did a very good job, and I just want to congratulate you on that. And it's clear that your staff is working hard. Your new hires, Brandy, has done a great. You're as frustrating as it is, and we get bogged down in all these things. You're starting to put the right people in the right places on your bus, and that's nice to see.
Thank you. They're working very hard.
Well, thank you, Ms. Luca, for your report, and we again appreciate everything that you do. You've got a good team and a culture, and things are going well. And Ms. Anderson will now discuss rules and policies.
Okay, thank you. We've got a lot to talk about today. So first up, we have the rule review update. This just gives you an overview of all the rules that we're working on and where they are in progress. There's nothing for you to vote on there. It's just an information piece. So if there's no questions, we can move on. If you have any questions, please feel free. Okay, no questions. So we'll move on to our next category, which is rules filed with CSI. We have two packets for you. The first, it involves rules received or comments received on the hearing rules. And the memo outlines the procedure and how this is in front of you. The rules were initially filed with CSI in October, and then the hearing unit asked to make some changes to Rule 4731.1303 to allow for virtual hearings on the motion of any party or hearing examiner. And CSI asked that we do another business impact analysis and obtain public comments another time. So we did that in January. The comments were due on January 22nd. We received two comments, and those are provided for you and outlined also in the memo. The first is from Dr. Bob Miller, and he requested, not with respect to the new rule, but one of the existing ones, 4731.1308, which has electronic filing as an option. He indicated that keeping paper filing as an option will be necessary for people that don't have adequate internet service. I have responded to him that this is an option, not a requirement at this point. And so it doesn't appear that any changes are necessary. The second comment that we received was from Levi Ketch of Graff and McGovern. He objected to 4731.1303, which would allow an electronic hearing on the motion of any party, but he was specifically objecting to the hearing examiner. He had concerns that the hearing examiner could unilaterally deny the respondent of the right of confrontation and due process, and that the Ohio State Bar Association is currently drafting model virtual hearing guidelines, and that the board should wait until those guidelines are ready. And then he also objected to the amendment of 4731, 13, 15, which have been previously approved by the board, to increase the time for a party to request to address the board from 5 days to 7. So I addressed those comments in the memo that you have. I think that the parties have multiple opportunities to raise due process concerns that will come to the board and to the hearing examiner, and then even on appeal. And so I think this would be a good tool for us to have moving forward. And I think the due process concerns can be dealt with multiple avenues that are available to the parties. And then with respect to the OSBA guidelines, that's a great point, and I think we do want to see what those are, but they're not ready yet, and these rules are up for their 5-year rule review. So I'd like to move forward with them now, if the board is okay with that, and then we'll revisit that if there are things in the OSBA guidelines that would cause us to need to make changes to our rule. And then with respect to the extension of time, that was requested by our staff to allow for getting the materials to the board in a timely manner. But as you know, the statute 4731-23C states that the board can approve a late request to address upon the vote of 3 board members. You do that regularly. So we wouldn't foreclose anybody from being able to present to the board. We would just take it to you as a late request under the statute. So based on all that, I am not recommending any changes to these rules based on those comments, but I would certainly be interested in your thoughts and any comments that you would have.
I only have one question, if I may, Mr. Chairman. What is it? What is the practical? How is it that you're doing on the extension of time under 4731-13 something, where you go to 3 votes of the board? I assume that you're talking to our 2 mute members plus the president, or how practically are you doing?
No, what happens with that, it actually gets scripted. So if somebody files a request to address, today it's 5 days. So if someone requests that late, then it gets scripted for the board president, and we ask the board in public session in front of the board, we received this request to address. It was not submitted within 5 days. If we change this rule, we'll be saying not submitted within 7 days. Does the board want to hear this? And the board always says yes. We may not have done that since we've been virtual, but I know we've done that when we were in person. And so it just gets scripted and it goes to the full board to decide that.
Okay. Thank you.
All right. Any other comments? All right. I appreciate that. I'll be communicating back with CSI, and then hopefully we'll be able to make forward progress on that. And then next, Nate Smith is going to talk to you about a dietetics rule that's pending at CSI.
Thank you. There are 3 dietetics rules that are at CSI. And during the comment period at CSI, we only received 1 comment. It was only to the 1 rule. So that is the only rule that I'll be addressing with you today, specific to the continuing education rule 4759-4-04. We received the comment from the Ohio Academy of Nutrition and Dietetics. The comment is included in your materials, as well as the memo and then the amendment to the rule. Basically, to summarize the comment, is the Ohio Academy of Nutrition and Dietetics would like the continuing education requirements for non-registered licensed dietitians to be even more similar to the requirements for the registered dietitians. So what that means is they would like the inclusion of a requirement for the development and documentation of a learning plan. So worked with the secretary and supervising member to draft some language, and was able to approach OAND and work through that draft with them. This draft of the language, which is in your memo on page 1, in the bolded language, and is also included in the bolded language in the draft of the rule attached, meets their concerns and requires this development and documentation of a learning plan. It also was discussed at Monday's Dietetics Advisory Council, and no objections were raised. OAND feels like it does meet their concerns, and it still preserves what were board priorities in this rule, which was to move dietetics to a biannual reporting of continuing education, like the other license types, and also to the board will no longer be routinely reviewing non-registered dietitian licensee continuing education learning plans. Instead, these learning plans, the obligation will be on the licensee to document and retain the learning plan and produce it to the board upon request if that licensee were audited. So with that, I would request approval to file this amended rule, refile this amended rule with CSI to move it forward, and happy to take any questions on that.
So moved. Second, Dr. Cockrell.
All in favor, say aye.
Aye.
Any opposed? That motion passes. And then, Ms. Anderson, I think you'll want to address the nursing consult agreement rules.
Yes, absolutely. So under the statute, the nursing board, like the pharmacy board, is required to consult with the medical board with respect to these rules for APRNs. So this morning, while the board meeting was ongoing, I received information from the Board of Nursing that they had received comments on these rules from their APRN committee. And I think just with the last minute nature of it, they don't need our comments until May 1st. So I'm going to pull these rules and bring it back to you in April with the comments from the APRN committee. But I just felt like with the heavy agenda that we have and the last minute nature, it would be better for us to address that in April. So I'm going to pull these.
May I ask if, and this may not be appropriate, but while you're talking to the nursing board, Dr. Rothermel raised a question this morning. I don't know if she's on the line. You were concerned about an issue. Did we want to try to approach, and maybe it's an executive director approach to executive director. You remember the question you raised about advanced practice nurses?
Yeah, I think Ms. Luca has already indicated that she is following up with the nursing board.
Okay, great.
Thank you. If you're all right, I can move on to the rules that were submitted for initial circulation.
Yeah, that'd be great.
Okay, so we submitted a number of rules for initial circulation, including our consult rules for PAs, which were in your packet but weren't in my memo, so I apologize for that. But we only received one comment, and that was really non-substantive. It was on the pronouncement of death rule, and it was about a historical issue, which I think does not necessitate us to make any changes. So I would like to get approval for filing these rules with CSI, if I could have that.
Yeah. So do I hear a motion to approve rules for filing with the Common Sense Initiative that's outlined in the memo from Ms. Anderson dated February 24th, 2021. Motion, please.
So moved, Dr. Cockrell.
Dr. Johnson.
Second, Dr. Johnson.
All in favor, say aye.
Aye.
Motion passes, Ms. Anderson.
Thank you. I appreciate it. Next, I'd like to move on to the delegation frequently asked questions. So this is follow-up from the last board meeting where you considered some specific surgical questions of as to whether RNs could do that work. And so I was tasked with putting together some frequently asked questions on the delegation of medical tasks. So, so we have 11 questions and answers that are proposed for you. Question number 7 and 8 deal with a specific question that had come to you last month about whether individuals who are licensed, but the work is not within their scope, can they be treated as an unlicensed person under the delegation rules? And the answer is probably, in certain circumstances. And then question number 8 is, may the delegation of those specific surgical tasks be made to an unlicensed person? The question we originally received was with respect to a nurse, but since a nurse is being treated as an unlicensed person, you really have to open that question up to be unlicensed people. Obviously it would be up to the physician, as explained in other parts of the FAQs, to make sure that that person could safely do the task. So I would appreciate any feedback that you have on those FAQs.
Kim, I think those are really well constructed. I thought they were very informative and important questions, and I thought the answers will be really helpful for the members. Ms. Montgomery?
First of all, thank you so much. First of all, thanks to Kim and your staff. Thank God people want to do these rules because they can get pretty bleary-eyed, and you've done a great job. And the FAQs, I just have to echo what Dr. Bechtel said. I love the simplicity and the clarity. It is just beautifully written. Whoever did that. I do have a question on number 3F. I know this sounds silly, but you say that what are the requirements for physicians delegating a medical task? And then you say on F that task is one that should be appropriately delegated. It seems to me that should be could be, because otherwise what you're doing is really just dictating a management decision. I'm not sure, if a doctor wants to do it, I don't think he should be told he has to delegate it. Do you understand what I'm saying?
Right. It's possible that may be directly from the statute or from the rule, but I can double check that.
And then on 11, let me see. I'm having a hard, no, it may be that I'm bleary-eyed reading these things and I don't understand, but I am having a hard time. What are the exceptions to delegation statutes and rules? The rules in this do not apply to the following. And then you say preventing delegation, preventing an individual. I'm trying to understand the construction there. I don't know what you're trying. I do not understand what you're trying to say there. So,
okay, it has to do with programs and services offered by county boards of developmental disabilities. So it's special within that particular arena, and these are all, I think, word for word what's in the rule.
No, the language you're using is preventing. Are you saying that these don't apply to individuals who are engaging in an activity as opposed to preventing an individual?
Right. It's the delegation rules are not going to operate to prevent these things from happening in these particular circumstances.
Okay, so I've got a wordsmithing problem with you. We can talk offline about it, because I think the way it's written, I have a wordsmithing question, but it's not worth wasting everybody's time on. But can we circle back on that?
Sure, absolutely. And like I said, I think it's language from the rule itself. But we can look at that.
Anyway, congratulations. Those are just very well. I wish the law was written as clear as your FAQs.
Thank you.
Dr. Feibel?
Yeah, just real quick to echo it. I don't want to belabor it, but it is true that we do I always say that our licensees, 99% of our licensees want to follow the rules, and we don't always do the best job of spelling those out. And this really is clear, and I'm super impressed. You did it certainly without my help, and I suspect without anyone else's help, and I'm pretty impressed. So great job.
Very good. Kim, do you need an official motion on that? What's that on the website?
Yeah, I think so. Do I need to work on a revision on 3 and 11?
Yeah, we might want to do that. Dr. Schonstein, I think you had a question.
So to your earlier point, the wording is substantially reflecting the 4731-2302. There is a should in the statute, in the rule, and this language is substantially word for word in terms of the acts that are prohibited under the delegation rules. So it's sort of been lifted very substantially. So unless we want to further modify, what this does right now is it just sort of keeps it consistent.
I just think it should be, an FAQ is in a prose to explain to a doc. And if I were a doc, I'd be saying, what do you mean I have to that it should be delegated? So, again, it's a wordsmithing question. I don't want to hold everybody up on it. So.
Maybe if I could have approval that I'll look at 3 and 11 and make some edits, and I can send that around. And if you're okay, I could bring it back next month.
No, I just think you should approve it and perhaps you could say something about the motion would be to approve with an understanding that there may be slight edits once there's a check with the statute and the intention. I don't think you should delay it. I don't mean to delay it. Dr. Schottenstein is appropriately reflecting what the statute says. I'm just simply saying as an FAQ, and we probably should not worry about being statutory. We should be worrying about being clear, but it's not worth the delay. I think we should just go forward with an understanding you could make a possible amendment that's slight and that we would approve it.
Okay.
We approve you're doing it without us going back.
Ms. Montgomery, do you want to make that motion then?
I move that we accept the FAQs as drafted with an understanding that there may be slight changes of wording in 2 sections, and that there is no need to bring it back to the board for final approval, that we finally approve it now.
Thank you. Second?
Dr. Johnson.
Okay. And we'll just vote. Everybody in favor say aye.
Aye.
Opposed? Motion passes. Okay, Ms. Anderson, you go on.
All right, thank you. All right, so next we have our light-based medical device rules. So bear with me, this is complicated. We have House Bill 442, which eliminates licensure for cosmetic therapists effective April 12th. And so now, cosmetic therapists in Rule 4731-1803 are licensed cosmetic therapists can do laser hair removal as delegated by a physician. And this rule, along with the other light-based rules, are pending at CSI and have been for a while, and we've had a lot of comments and discussion about that. So in order for cosmetic therapists to be able to continue doing laser hair removal after April 12th, we've got three options. One is a statutory change, and I think our legislative staff has, been speaking with the legislature. This probably will not happen before April 12th. The next is the possibility of an emergency rule. And so we'll talk more about that. And then the third possibility is to waive enforcement of the rule for cosmetic therapists. First of all, I'd like to talk about the emergency rule, and you have a draft emergency rule in front of you. Now, we have not done an emergency rule at the medical board for a very, very long time, and it's a special process. We have to have an executive order from the governor allowing us to do it, and it is only good for 120 days. When the 120 days expires, the rule expires. So you also have to file your permanent rule at the same time. So that's why we're going to talk about the emergency rule and the permanent rule today. So our next board meeting is not until April 14th. That's 2 days after the effective date of House Bill 442. So that's why we need to talk about this and make a decision today. We are in discussions with the governor's office with respect to an executive order. So we are making good progress with that. The emergency rule that you have in front of you would make some changes that would eliminate the reference to cosmetic therapists as being licensed by the board. And so specifically, it changes the definition to cosmetic therapists from being currently licensed under Chapter 4731 to being a cosmetic therapist who was licensed as of April 11th, 2021. So it lets those individuals who were licensed at that time continue doing the laser hair removal. It deletes the language in paragraph B about cosmetic therapists being licensed by the board. In B1, it changes the approval of the course. So for cosmetic therapists to be able to do light-based or laser hair removal without having a physician on site, they have to have passed a course that was approved by the medical board. So we're changing that to say approved by the delegating physician. So the physician that's delegating the laser hair removal to the cosmetic therapist. There are probably, the cosmetic therapists now have already passed that course that was approved by the board. And then in paragraph G, we're taking out the minimal standards violation for cosmetic therapists because they are no longer licensed by us. And we're adding in that a violation of paragraphs B or C of this rule constitute the unauthorized practice of medicine under 4731.41 of the revised code. So because we no longer have jurisdiction, we can't take a licensure action for minimal standards. But if they're doing things not in accordance with this rule, it could be considered the unauthorized practice of medicine. I am also recommending in paragraph A5A that we update the language with respect to physician assistants. This is just a really old rule, and it talks about a supplemental utilization plan for a PA, and that hasn't existed for a long time. So just while we're in here cleaning it up, I thought we should just add the language with respect to a physician assistant, that it's with whom the physician has an effective supervision agreement authorizing the service. So that's just a cleanup. So this is what I'm proposing for the emergency rule. Are there any questions? Okay, thank you. And that it would allow people who are doing laser hair removal now to continue for that 120-day period. So next, we need to talk about the permanent rule, and this gets a little bit more complicated because we have this major rewrite that's at CSI right now, and a lot of this work has hinged on what kind of supervision or training is necessary for physician assistants. And so at the December policy committee meeting, we talked about this and made a number of changes that were recommended. And the policy committee advised me to take that to the PAPC. And so in January, the PAPC did look at those proposed changes, and they had some additional questions. So I would like to talk with you about those. So they had questions regarding 4731, 1803, A3, A4, B3, and B4, and 4731, 1804, B2, and C2. So it's before the laser can be used, or the light-based medical device can be used for non-ablative vascular lasers or for laser hair removal, the physician who's delegating this has to have an initial in-person review with the patient to determine that the application of the laser is appropriate. And then after the initial application, the physician has to in-person review the patient again before there are subsequent applications of the laser. So the question that PAPC members asked was if the initial review was required, or if that could be delegated to the physician assistant, and if this requirement could be completed via telemedicine, which would necessitate that we would just remove the words in person in those sections. So I did have a chance to talk with Dr. Bechtel about this and Dr. Feibel. And Dr. Bechtel felt, and you can definitely jump in, Dr. Bechtel, but felt that a physician would be able to do this work via telemedicine in a safe manner.
Yes, I'd like to comment on a couple of things. I know the PAs were concerned that it would require a physician to evaluate a lesion prior to doing the laser, and then to evaluate the patient after the first laser treatment. And I think the board needs to understand we're expanding the ability to do lasers beyond physicians. Cosmetic therapists and nurses have been able to do laser hair removal, but non-physicians have never been allowed to do vascular lasers. So this is something that's new. And there have been a lot of physicians that express concern about non-physicians lasering the wrong lesions, like a skin cancer or something else that might have adverse outcomes. And also the fact that there's been a higher instance of scarring from laser treatments in other states by non-physicians. And I appreciated those concerns. And I think patient safety is really, really important as we're expanding laser technologies with vascular lasers beyond the physicians. We need to protect the public. And I do think it is critical that we make sure that non-physicians are appropriately treating lesions. We don't want somebody doing a laser technique on a melanoma that could then turn out to have really negative consequences later on. Or if somebody's doing the laser inappropriately, end up with significant scarring that's lifelong. And I think that initial evaluation and I think the evaluation after the first treatment is critical to avoid those complications. Telemedicine has really expanded a lot in dermatology. We use it constantly all day long, and we see greater and greater resolution with our cameras and our cell phones and with a lot of our other digital equipment. That the digital resolution is pretty significant. And I didn't have objections to having them do that initial evaluation using telemedicine prior to treating a lesion or afterwards, if it would help with patient care and make things smoother and to flow better. And I felt the technology had gotten to the point that was satisfactory.
Great. So, and then, so I think if the board is okay with this, what we would like to propose for the permanent rule is that the in-person requirements be removed from A3, A4, B3, and B4 of Rule 4731-1803, which would allow the physician to do the initial follow-up visit via telemedicine, but that we keep the initial follow-up visit by the physician for the laser hair removal and then the non-ablative laser.
And then that is, of course, as the telemedicine bill goes through as it is, that doesn't restrict they'll have to comply with the telemedicine bill as is.
Right. If there's a statute that changes that, then, the statute would control.
That's correct, Dr. Feivel, that's correct, yes.
And then the other thing we wanted to talk about that was raised deals with the Rule 4731-1804, B2 and C2. And this is language about phototherapy and photodynamic therapy. And so again, we have the telemedicine issue raised, and then also whether the physician needed to do the initial visit prior to allowing a PA to administer the phototherapy or photodynamic therapy. And when I talked with Dr. Bechtel, he felt comfortable that a PA would be able to apply phototherapy or photodynamic therapy without having the initial physician visit, and also that for the other licensees, the registered nurses, licensed practical nurses, and certified medical assistants, that could be done via telemedicine. So we would propose those changes too. Okay.
For the board, phototherapy is commonly used to treat psoriasis, and it's been in use for 40 years. And it's similar to like getting in a tanning bed where you get in a light box and you're exposed in a very regulated way for a certain amount of light. And it's very carefully controlled. With photodynamic therapy, it's sort of a continuation of how we treat precancerous lesions, like with lipid nitrogen or 5-FU. You paint a solution on the skin, usually leave it in place for about an hour in the office, and then expose the patient to a specific blue light for about 15 minutes. There's not any change in duration of the light therapy or intensity. It's very standard, consistent with every application. So there's not any variation in how much light's exposed or the intensity. Pretty standard. And I felt that a PA should be able to do that, especially working along with a physician who's supervising them. It would not require initial physician evaluation.
Thank you. The other thing, so we've got a number of edits related to PAs that are outlined in your memo for the permanent rules. The other thing I'd like to talk about is 4731 1803 capital B5 little b. And this is where the permanent rule would be different than the emergency rule with respect to cosmetic therapists. So I'd want to point that out to you. So in the emergency rule, it's an emergency, we're keeping status quo, while we're working through this. So anybody who, as of April 11th, was licensed as a cosmetic therapist to do laser hair removal could continue doing that. That is proposed to be in the permanent rule. Anyone who was licensed by the board as of April 11th, 2021. So that is the same as the emergency rule. But then thinking about how could someone be able to do this in the future if they hadn't been licensed already, what we have proposed is that they have completed a cosmetic therapy course of instruction for a minimum of 750 clock hours, which is what is the current requirement, and received a passing score on the certified laser hair removal professional examination administered by the Society for Clinical and Medical Hair Removal. Our current cosmetic therapy exam is the CCE exam, which is for electrology, by this society, the Society for Clinical and Medical Hair Removal. They have a test for laser hair removal. So that is how that was selected. So that would, that's different from the emergency rule, but it would allow additional people to be able to do this in the permanent rule if they met those requirements. So I wanted to point that out to you. Everything else would be the same as the emergency rule with respect to cosmetic therapists. Okay, if there's no other questions, I'd like to walk you through okay, Dr. Schottenstein.
So sorry, I just want to confirm, the recent 442, it cut down massage therapy hours to 600. Did that happen with cosmetic therapy as well?
No, because they didn't have it anymore.
Okay, just double checking. So statute does not weigh in that regard on cosmetic therapists?
No, because we no longer have the authority to license them.
Right, forgive me. So just to be clear, the 750 to 600 was in 442. Was there anything about cosmetic therapists in 442 about a reduction of requirement of training?
No, because it eliminated licensure.
Okay, altogether. Okay, great. Thanks.
Kim, do you need an official motion or vote on this?
I do. So I want to kind of walk you through. I've got 6 different things that I need you to do in this motion. So the other thing, in case we are not able to get the timing of this right, I think we will, but it does need to be very precise. I'm also asking for a waiver of enforcement for the cosmetic therapists if we're not able to get the emergency rule in place. So the requested action I have is explore the possibility of filing an emergency rule with an executive order, approve the draft emergency rule language, approve the amendments as we've discussed and as were outlined in the memo for the permanent rule. Approve filing the permanent rules 4731 1801 through 1804 as soon as they're released from CSI. Delegate to Dr. Bechtel as the board president the ability to make additional necessary changes to the emergency rule or permanent rule if needed between the March and April board meetings. So we've done that in the past, sometimes where we've had things with timelines that were happening between board meetings. So that would be helpful if there's something that comes up, and then we would bring it to the board to inform you about that afterwards. But because we need to make these changes before the next board meeting. And then the last one is waive enforcement if we don't have an emergency rule in place prior to April 12th.
So moved, Dr. Johnson.
Thank you. I think Ms. Montgomery has a question.
No, I was going to do what Dr. Johnson did.
Oh, okay.
So we have a motion by Dr. Johnson, second by Ms. Montgomery. And all in favor say aye.
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 Opposed? That motion passes.
All right. Thank you. I appreciate it so much. All right. I think the next thing we have is the vaccine protocol that Nate Smith is going to talk about.
Thank you. In your materials, you have a memo from me as well as the actual order, the Director Journal Entry INRAE COVID-19 Volunteer Vaccine Providers. So this protocol was put out pursuant to, by the Department of Health, pursuant to statutory authority in 3701.048 that allows for protocols for the administration of drugs in a declared emergency. So as part of the pandemic response, the Department of Health has the ability and authority to put out protocols related to the administration of drugs. So what this protocol does specifically is it authorizes physicians, MDs, DOs, and DPMs, physicians assistants, and respiratory care professionals within the scope of their respective licensure and according to the competencies set forth by the respective board to administer, deliver, or distribute Pfizer and Moderna COVID-19 vaccines. That was the what was specified in the order. The way this would work is that the individuals who fall under the protocol would need to become registered volunteers, and then they would be actively deployed by a medical reserve corps unit in support of dispensing the vaccine. So practically, as you all know, the vaccine effort is really ramping up. And this protocol really standardizes the training and the procedures. This protocol is a 13-page document that you all have that really is super detailed, very granular detail on the different procedures. Anything from information given, pre of the assessment of the person to how to deal with, adverse allergic reactions. So the protocol also speaks to, and also allows medical students, in addition to pharmacy interns and nursing students, who are sufficiently advanced in their education with the necessary competencies as set forth by the licensing board. And then the last thing is it gives training requirements. So the protocol specifically says that personnel administering vaccines must receive comprehensive competency-based training on both vaccine administration as well as on recognition and management of anaphylaxis before they're able to administer the vaccines. So it also says that the personnel must comply with competencies set forth by the board. If the board doesn't set a competency, then the personnel would have to meet the training requirements that are stated in the protocol order itself, which I've listed. There's a couple training modules that, in lieu of the board setting competencies, that these people who would fall under the protocol would have to meet. One's by the CDC, and the other one is an anaphylaxis sort of electronic learning module as well. So the reason why I'm addressing the board today on this is the order specifically tasks the licensing board, specifically the medical board, to set competencies for physicians, PAs, RCPs, as well as medical students for COVID-19 vaccines. As stated earlier, the board it doesn't have to do it, but it could do it. If it doesn't do it, then the fallback position would be those electronic learning modules. So I have laid out in the memo on page 2 of the memo 3 different options that could work. And what I would like today is if you would discuss and select one of those competency options or a suitable alternative. The options are pretty simply laid out. Option 1 is they go in order from most arduous to least. Option 1 is we would require that the physicians, PAs, and RCPs have an active license in good standing and not be under suspension or a probation order, and then complete the e-training. For the medical students, we require that they have at least 2 years of medical school and or have medical school clinical experience within the last year of giving a vaccination of any kind. So that's option 1. Option 2 is for the licensed professionals, no competencies beyond the e-training. And then the medical students would have to have the competency of being in medical school for 2 years or having administered a vaccine within the last year. And then option number 3 is no additional competencies, just complete the e-training for both the licensed professionals as well as the medical students. So turn it over for discussion now as to which of these 3 options or another one that you would think is appropriate to for us to then notify ODH via letter that these are the competencies that the board has set pursuant to the protocol, so that when they allow people to become these registered volunteers and vaccinate through the Medical Reserve Corps, that the people will have completed the appropriate competency as laid out by the medical board.
Dr. Reddy?
I have a question. It only addresses the Pfizer and the Moderna vaccine. And as you all know, we're going to have more vaccinations. Is it appropriate to include them or not?
So and we don't have any official guidance by ODH on this. My suspicion is that there will be additional amendments to this order, and that the board could certainly give guidance as to competencies for the Pfizer and the Moderna and all future COVID-19 vaccines and set the competencies that way, or we can continue to bring them back as ODH amends its order. But I would expect in the future that we will see some sort of communication from ODH as additional vaccines come online, additional manufactured vaccines come online, to incorporate them into the same order by amendment of some sort.
Nathan, I had a question. I know that the vaccine clinics are already ongoing, and that we have nurses and physicians that have been volunteering to help. I know Franklin County has one. What type of training are they having currently? Are they going through these online courses on vaccination, or what are they currently doing right now?
Dr. Bechtel, I think that they have a very, they have their provider website where people have to get registered. I know that there's also additional federal guidance on this. I think that this ODH protocol is an effort to really standardize and make that kind of training mandatory. I don't have an exact answer to you on what all has been going on, but I think this is an effort to standardize it and to make sure that everyone is doing it. And particularly if you're bringing in some other professionals who may not be doing it. The additional thing that I didn't mention, because it's not really medical board specific, but among the other people that were included in this protocol are dentists, nurses, optometrists, pharmacists, EMTs, and veterinarians. So I think that could also have something to do with it in the sense that you potentially are bringing in other professions that, might not be vaccinating people all the time. So.
Dr. Schonstein?
Hi, thank you. So given the urgency of the need, I think that we want to proceed in such a way that we facilitate getting as many shots in as many arms as possible, but in a safe way, of course. And so I actually sort of looked over these two training courses. I guess I was wondering if there is a live demonstration, if somebody is taught the practical application of the giving of the vaccine, as opposed to just going through the slides and the videos of the training modules.
That I could not answer specifically. I guess the way I'm reading this protocol order is that they're going to be deployed in a medical reserve corps, which I would imagine that is a fairly substantial group of people that, they would be doing it together, vaccinating a substantial number of people at a time. So one could presume that there could be some additional on-the-job training, but that's not specifically addressed in this protocol.
I'm a member of one of the MOCs. I think there is a medical leader for a group of people who are going to vaccinate, and it will be under the guidance of the medical leader. They're going to provide the vaccination.
Are there, does anyone have a preference as to which of the three of the competency options, or are there a different one that you'd like to consider?
Dr. Schonstein?
So, thank you. I don't have a strong preference, but what I guess I would say is that if option 3 is essentially the default option for a variety of different specialties outside of our board, and that has been judged to be, safe and effective for the administration of vaccine, then I think that's probably where I would, where I would lean as well. Again, with the interest of not creating roadblocks to getting people out there who are able to safely administer vaccines.
Dr. Schonstein, I would agree with your opinion on that too. Dr. Feibel?
Yeah, so would you be okay with a suspended physician? Unless I'm reading this wrong. A suspended physician being giving this vaccine? I guess I'm not under suspension or under a probation order.
Yeah, I'm looking for it. I thought I saw something like
I
that.
think you'd be excluded from doing that if there's any disciplinary.
Option one says that they have to be currently licensed, have an active license, and not under suspension or under a probation order. So my assumption for option 2 is, or option 3 is that they can be under suspension order as long as they have MD behind their name or whatever behind their name, they can still give this. I don't know how comfortable I am with that philosophy, but that's just me. I'd be open to listen.
Well, it says in the order, the volunteer vaccine providers, where it describes physicians, at least, that they're, authorized to practice. And so, of course, that wouldn't be, relevant to students, since they aren't licensed to begin with. So I'm thinking if you're suspended, you're not authorized to practice.
That was my opinion. Nate, do you have any opinion on that too? On category 3, if anybody under suspension would be able to give the vaccination.
Yeah, I think I put the suspension language in there to go along with the probation language. I think if you were on probation, you would be authorized to practice. Under suspension, I think it's an arguable proposition. You know, you're still licensed if you're under suspension, so you're still authorized. So I just put that together as sort of a belt and suspenders approach of, you know, the most demanding competency being that would you want someone who was having recent disciplinary action, serious disciplinary action in the sense that they were suspended or under a probationary order to, for a variety of things to be able to do this. But I think it's probably most applicable to the ones that are under probation.
I mean, the fact that you have this in there under option 1 means that if you're under suspension or probation, you can certainly argue that we authorized them to go ahead and do it because we didn't approve number 1. I mean, if this document ever got out, it certainly would be a defense to somebody. I think. I mean, why would that even be in option 1? What's the difference between option 1 and option 2 then?
Well, yeah, option 2 is the only competency that the board would require is the completion of the e-training as specified in the order itself.
So again, I read that as somebody under suspension or probation. Since you have it in option 1, the only difference between option 1 and 2 is that. I think.
That's correct. I mean, these were options that board staff, me in particular, drew up as potential choices for you. It's certainly, the board is authorized to go in whatever direction it wants with this, setting as little of a competency or as much of a competence as you would like. I think that Dr. Bechtel and Dr. Schottenstein make a good point that being suspended and not being in practice is a good argument that you're actually not authorized at the moment to be practicing medicine as a physician. So I think we can construct the language and communicate that language to ODH however the board sees fit.
Dr. Rothermel, did you have a comment too?
Under number 1, I think if they have an active license, we don't have to say and not be under suspension, because if they're under suspension, they don't have an active license. So that's just a little duplicative. But the other thing to consider is if we require an active license, I know that they were really recruiting retired physicians and healthcare workers who may not have an active license. And we have to consider that as well.
Yeah, that's true, Dr. Rothermel. They've been trying to recruit retired physicians with non-active licenses to help volunteer. Dr. Feibel?
I think you bring up a good point to that. I personally like option 1 with the understanding that an active license in good standing or a retired physician who retired with an active license in good standing, to add that language in there. And that way, and I don't really care about probation, because if they're under probation, they have an active license, but just take out the suspension part. And I don't think a suspended physician should be able to do this. I think that's
right. But they're not going to have an active license anyway.
Right. So I agree with. I guess I was agreeing with you to take out suspension or under probation and say have an active license or in good standing, or have. It doesn't even have to say in good standing. It could just say an active license, or a retired physician who retired with an active license in good standing, something like that. Somebody who hasn't given up their license in lieu of disciplinary action. I don't know how to put them words, but those are the people that I think should be doing this.
And
Dr.
maybe say
a motion along those lines for option number 1. Is that possible, Nate?
Dr. Becker, can I respond to one thing on the retirees? I think there is what is more or less temporary legislation. I believe it's Senate Bill 310 that allowed these retirees, I believe it was until May 1st. So that part is going to be kind of time limited out.
Okay.
And I think the way the order is written, a physician authorized under Chapter 4731 to practice medicine and surgery, to me, that would seem to be somebody who's actively authorized in present time. So I wouldn't believe that a retiree who's no longer carrying an active license would be included in that.
Okay.
But we could take out the not be under suspension portion and just say require that the physician have an active license in good standing with the medical board and not be under a probation order and complete the e-training.
Are you saying that a retired physician in June, assuming something doesn't change June 1st, would not be able to do this?
I'm saying there was a specific statute that allowed physicians who allowed their license to expire. I believe it gives them authority until, I believe, May the 1st to be able to practice even under the expired license for COVID-related situations. So I don't believe that the authority under that legislation will proceed past May the 1st.
But couldn't we, couldn't we allow retired physicians to perform this, or retired licensees who retired in good standing to do this? Wouldn't that be allowed?
I think that we are bound by the Department of Health's order that says a physician authorized under Chapter 4731 to practice medicine and surgery. So that's where we have to start, but they have to be actively authorized. And from there, we can specify a competency within that group of people that are active practitioners.
Does anybody want to make a motion for 1, 2, or 3 options?
I think we're brain dead.
Well, I would move that we require that physicians, physician assistants, and respiratory care professionals have an active license in good standing with the medical board and complete the e-training specified in the order.
Okay.
I second that.
We have a motion and a second. All in favor, say aye.
Aye.
Opposed? Motion passes.
May I ask one further question, and hopefully this will be short. Do you have an opinion on the medical students?
I mean, they've never traditionally been under our purview, historically. So,
Yeah, I agree. I don't know if our opinion matters, but a medical student did mine in January, and I didn't die. That's good to know.
The same as the retired physician. If we can't say a retired physician can do it, we certainly can't say a medical student can do it. I don't think, as a medical board.
Okay.
Nate, to your earlier point, are we allowed to just abstain from weighing in on the medical student question?
Yeah, I believe that the order under the training section says that the vaccinating personnel must comply with any competencies. If the board doesn't set a competency, then it reverts to that e-training. So we could certainly go with, we set no additional competencies regarding medical students. That would be entirely appropriate.
Okay. Thank you.
Is that the way the board wishes to communicate that?
Yes.
So yeah, I'm a little confused. If we can't regulate the medical students, can we? So,
Yeah.
No. I mean, I'm not, I don't want to even say that. I don't want to say no further restrictions on medical students, because that's not our purview to say, I don't think. That needs to come from the Ohio Department of Health, I think, or some other agency other than us, other than we.
I think we can communicate this back to ODH with the board's observations. And prior to the drafting of it, we also did let them know that they do not fall under us.
Okay. Thank you.
Thank you.
Ms. Anderson, Mr. Smith, any further comments or?
Not on this, not on vaccines, I don't think. Are we ready to move on, or do we need a vote? Did we already vote?
We already voted, yes.
Okay, all right. Are you ready to move on to evaluation and treatment rules?
Yes.
Okay, all right. These are the last rules for today. So at the February Compliance Committee meeting, there was a determination, and I think it was also discussed today a little bit in compliance before we had the technical issue, that for certain license types, dietitians, respiratory care professionals, radiologist assistants, and genetic counselors, that they should be permitted under our rules to have an outpatient evaluation, and then like MTs and CTs, but CTs won't have it anymore. So what you have here are 3 rules which have amendments that allow for these additional license types to have an outpatient evaluation, and when the board is ordering treatment, to have outpatient treatment, which is just like what the MTs have. So outpatient evaluation and outpatient treatment. For OneBite, they'll have outpatient evaluation, and then OneBite, under its particular rules, says that the treatment is based on an individualized treatment plan developed by the treatment provider. So OneBite treatment stays the same. It's flexible based on the recommendation of the treatment provider. The evaluation for these license types moves to outpatient. And then if the board is ordering treatment for these individuals, they would get outpatient treatment just like MTs. And then we also did some cleanup language to remove cosmetic therapists since they're no longer our licensees. So if the board is okay with this draft of these 3 rules, then we would send those out for initial circulation.
Dr. Rothermel?
I just have concern that the first paragraph, to me, implies that they will have outpatient treatment, because I think that it should be based on the evaluation and the recommendation. There are some circumstances when MTs should probably have inpatient treatment.
Okay, well, they don't have it now under our rules.
Well, not MTs, but, well, I'm talking about these others. But you mean they are obligated to just have outpatient treatment? And we're okay with that, even if the evaluation says they would benefit from residential treatment?
Is this a
we have to separate board order?
Are you talking about treatment or evaluation?
Treatment. The evaluation can be outpatient.
Right. Right now today, and for many years, MTs and CTs ordered by the board have an outpatient evaluation and outpatient treatment. And that's been in place for many years under our rules. And then with the development of OneBite, the way OneBite works is they have the evaluation as set up in this rule 1605, and they have treatment based on what the treatment provider tells them they need.
That's what I'm suggesting would be more appropriate even for our board.
Okay. That's a change from what we currently have, but we can certainly talk about that.
I think I I would like to talk a little bit in compliance. What are we talking about in compliance committee if you're doing this already? I guess I'm missing something.
Well, we, and maybe we're incorrect, but we thought that the compliance committee wanted us to do this from the February board meeting. And so that's what we were doing. So we can pull it and talk about it. You know, we're just trying to effectuate what we thought the compliance committee wanted us to do.
Kim, do you think in sake of time, do you think we could maybe table a vote on that today and then maybe take it back to the compliance committee next month to make sure we're all.
Absolutely. Yeah, no problem at all.
Or actually, this afternoon, which we have a lot to do. We didn't really get through much of our compliance committee before we got bumped up.
Right. Either one is fine with me.
Okay. Why don't we go ahead and maybe table a vote now, and then we'll turn it back to the compliance committee then.
Okay, thank you.
Ms. Anderson, I think any further things to come before the board right now? I thought...
not for me, but I think Chelsea has a legislative update.
Yes, I was going to go next to that. Yes, yeah. Ms. Wonsky, do you want to go ahead with the legislation? And thank you very much, Ms. Anderson. A lot of work today. Thank you so much.
Agree.
Okay, well, thank you and good afternoon, Dr. Bechtel and board members. Thank you for the opportunity to provide an update on legislative matters currently impacting the State Medical Board. Our biggest priorities currently remain the budget and the Interstate Medical Licensure Compact. We are also closely monitoring House Bill 122 regarding telehealth and Senate Bill 55 regarding massage therapy licensure, among several other bills. We are pleased that our initial budget request was granted in the executive version of House Bill 110, and will continue to advocate for that request as we continue to carefully monitor the language through the remainder of the process. As Stephanie mentioned earlier, over the past month, she and I have been meeting with legislators on the finance committees and subcommittees in both chambers to address any questions that they might have about our board or our budget request. And as many of you probably saw last month, Stephanie offered testimony for the House Finance Subcommittee on Health and Human Services. We now wait for the House version of the bill to be passed before it will make its way through the Senate committee process. And I will be sure to keep the board updated as the bill moves its way through the many steps of the lengthy proceedings. Senate Bill 6 would require Ohio to join the Interstate Medical Licensure Compact. In the past few months, Stephanie and I have met with the bill sponsor and co-sponsor to continue to reiterate that this language will provide operational challenges and could slow the process to licensure for out-of-state applicants. Marshall Smith, the executive director of the IMLC, provided a presentation before the committee, the licensure committee rather, this morning, and answered board member questions. We appreciate him giving us that time. It is important to note that the bill language regarding the compact is a contract and cannot be changed, but amendments may be added to allow for some flexibilities around implementation of the legislation. At the last board meeting, I had mentioned that we made a request to the committee chair to extend the implementation timeline from 6 months to 1 year, and also asked for appropriations for startup costs. And I'm happy to report that our amendment was approved and was added into the bill language this morning in the Senate Health Committee. We appreciate the work of the bill sponsor, Senator Roebner, as well as committee chair, Dr. Huffman, and their staff for adding our request to the bill. House Bill 122 was introduced on February 16th and would permit specified language that is nearly identical to House Bill on the last General Assembly. Senate Bill 55
I'm sorry, Chelsea, you seem to be freezing up. We can't hear you.
Can't hear.
Intent in its.
Can't hear you.
Oh no.
Maybe.
Wait, can you hear me now?
Yes.
Yeah, you'll have to back up. Did you lose me? Where did I leave off? Did you hear the telehealth?
No.
No? Okay, so I had mentioned House Bill 122 was introduced last month and allows healthcare professionals to provide telehealth services. And this is language that is basically identical to the language we saw during the last General Assembly in House Bill 679. Senate Bill 55 requires individuals practicing massage within the state to obtain a current license with the medical board. This is language that was also introduced during the last General Assembly and is intended to curb the illicit massage operations in the state. And finally, please note that there is a document in your board materials, frequently asked questions, that addresses questions around the cosmetic therapy and Oriental medicine practitioner license elimination, along with the legislative tracker and summary. And finally, the last item that I have to report is regarding controlling board. On Monday, a request to extend the contract with attorney hearing examiner Rhonda Szymanski was approved. So the board may now continue to utilize Ms. Szymanski's services for the remainder of the fiscal year. This concludes the legislative update, and I'm happy to answer any questions.
Mr. Kandidakis?
Chelsea, you might have mentioned this when you froze not you froze, but the Zoom froze. You do a great job. Senate Bill 9 is getting voted out of the Senate today, and that puts some more additional restrictions on rulemaking and what have you. Is that applicable to us, or are we exempted from that?
Currently, the language addresses executive agencies only. So boards and commissions are exempt from that. I do have it on the tracker. We're keeping an eye on it because, I wouldn't be surprised if we were added, and it could come to us down the road. So it's always something that we're watching, but we are currently exempt from that language.
Awesome. Thank you.
Mm-hmm.
Thank you, Ms. Wansky. Ms. Reardon, do you want to now give the Dietetics Advisory Council report?
Sure. Thank you, President Bechtel and members of the board. The Dietetics Advisory Council was held on March 7th, which was Monday at 2 p.m. The minutes from the December 2020 board meeting or council meeting were approved. Chelsea Wansky, the board's legislative director, gave an update on pertinent legislation going through the Ohio General Assembly. Attention was paid to the rule that was discussed today regarding updating evaluation requirements for the allied professionals, and that will be taken back to the compliance committee. Amended Rule 47590404, which Mr. Smith spoke about earlier, which is a rule that was amended at the request of the Ohio Academy of Nutrition and Dietetics regarding non-licensed dietitians' continuing education requirements, was talked about today during our board meeting. Some members of the Dietetics Advisory Council do have terms that are expiring, and we will be working with the OAND and getting applications, interviewing, and getting those back to the board and to Dr. Bechtel for review. The next meeting that this Advisory Council will have will be on May 10th, and this concludes my update. And if you have any questions, I'd be happy to entertain this.
Any questions? Thank you, Ms. Reardon. Dr. Caccarella, do you want to give the Respiratory Care Advisory Council report?
Sure. Thanks, Dr. Bechtel. The Respiratory Care Advisory Committee Council met yesterday, March 9th. Chelsea Wansky gave an update on pertinent legislation going through the Ohio General Assembly. Attention was paid to the rule being discussed by the medical board today to update the evaluation requirements for impaired respiratory therapists and other allied professionals, changing the requirement of a 72-hour inpatient evaluation to an outpatient evaluation. There was also discussion notifying the council of the recent Department of Health, Ohio Department of Health order, including respiratory care professionals as COVID-19 volunteer vaccine providers, and as discussed earlier today. The Respiratory Care Advisory Council will have 3 members whose terms will be expiring, and we're working with OARC to get nominees, and the board will be working toward an open application and appointment process in that regard. That concluded yesterday's meeting. The next meeting of the Respiratory Care Advisory Council will be held on June 8th, 2021, the day prior to the June meeting of the full medical board.
Thank you. Thank you, Dr. Cockrell. Any questions? Now I'll give the Medical Marijuana Expert Review Committee report. The Medical Marijuana Expert Review Committee met last month on the board meeting on February 10th, and the committee discussed petitions for adding new qualifying conditions for the treatment of medical marijuana. We received between 30 petitions between November 1st and December 31st of 2020, wishing to add new qualifying conditions for medical marijuana, and for new board members to put forward a petition for a new medical indication for medical marijuana, new qualifying condition. You have to include quite a few things to meet that that standard. You have to have be very specific on what qualifying condition you wish to add. You need to have some experts who specialize in the study of that disease or condition, have information available. You have to really provide relevant medical or scientific evidence to support the use of medical marijuana. You need to also comment on whether or not current standard of care is inadequate to deal with that condition, and also to have a letter of support from a physician knowledgeable of the use of medical marijuana in that specific disease. So these are standards that kind of need to be met. And we divide them into 4 categories. Category 1 is that the petitions have failed to meet the statutory and rule requirements. They haven't presented enough scientific evidence. They don't have support from another physician. Category 2 is the petitions were very close to meeting the statutory rules and requirements, but have minor details that are missing that maybe the board could work with. Category 3 are petitions that were submitted for a condition that is really already covered by the current qualifying conditions. And then category 4 are petitions for qualifying conditions that really meet the statutory and rule requirements that we would then go on for further review. The committee discussed the petitions and voted to move 3 of the petitions into category 3 because we thought those conditions were really appeared to be already covered by chronic pain indications. Specifically, the committee voted to move the petition for complex regional pain syndrome type 2 from category 1 to category 3, and to move the petitions for arthritis and migraines from category 4 to category 3 because we felt they were already covered by existing qualifying conditions. The committee has recommended rejecting petitions in category 1, but we will plan to present those petitions to you formally at their next board meeting for a vote. The committee also recommended rejecting the petitions in category 3. Again, these are conditions we thought were already covered, and we'll have administrative follow-up to the petitioners and inform them that the conditions may already be qualified for treatment with medical marijuana if they're already covered. There were no petitions in category 2. The committee is moving forward with review of petitions in category 4. And the staff will identify an expert in neurologic conditions to review the petitions for restless leg syndrome, Huntington's disease, and spasticity and persistent muscle spasms. So these petitions will undergo further expert review. And the staff will also identify an expert in palliative care or related field review the qualifying petitions for terminal illness. And those will undergo further review and then be brought to the board for your consideration. For the petitions for autism spectrum disorder and panic disorders with agoraphobia, the committee decided to proceed without obtaining outside expert review because the committee has considered and has outside expert reviews on these conditions in the past. And for these conditions, the board will act as its own expert. The committee established a public comment period on February 11th to February 26th, 2021. to receive comments on conditions that we placed in category 4. The committee will meet this afternoon after the board meeting to review and discuss these public comments. Lastly, the committee decided to send a caution letter to physicians who hold a certificate to recommend that have not responded to the CTR physician survey as required. And this concludes the medical marijuana expert review report. Any questions, Dr. Schoenstein?
Hi, just to clarify, in terms of migraine, we had specified chronic migraine as the condition that we were moving to category 3 as opposed to just migraine.
Okay, thank you so much, Dr. Schoenstein, for the clarification.
Of course.
Any other questions? We'll be coming back to the board next month with some more formal recommendations. And I think now next, Dr. Soin will have you go forward with the ICD-10 data review.
Yes, hello, thank you. The ICD-10 committee did not meet in March. We last met in February. Our next meeting will be in April next month, where we'll go over the action items we discussed at the February meeting. That concludes my report.
Thank you, Dr. Soin. Dr. Schottenstein, will you give the FSMB recommendations review committee report
Sure.
now?
Thanks very kindly. So the FSMB committee met earlier this morning to discuss the recommended statutory language regarding the addition of a consumer member to aid in the supervision of investigations. Staff had provided us with draft language to that effect. The draft language requires board approval of consumer member participation. The language appears to provide flexibility regarding the ability to specify consumer member involvement in either specific steps in the process or approval by category, such as for sexual misconduct investigations, and the ability to expand to other categories beyond that. The language allows the president to have flexibility regarding the appointment process in determining which of the consumer members is appointed. And finally, the board may rescind the authorization of consumer member participation in investigation supervision if needed. The draft language was discussed by committee members and staff this morning at length. The emphasis appears to be on making sure that it provides maximum flexibility going forward, and the consensus was that this is the case with our current proposed language. So with this language, consumer members may be appointed to supervision of investigations one at a time or rotated through, or potentially one consumer member could be appointed to one category of misconduct while another is appointed to a different one. The language allows for blanket approval of consumer member participation by the board and does not require multiple individual board votes. The FSMB committee passed a motion this morning approving the draft language. If the full board concurs, then this language will go to interested parties. We hope to include it in the package of sexual misconduct legislative proposals that we have previously approved. So it would all go out as one package together. Any discussion in this matter? So hearing none, may I please have a motion to approve the proposed statutory change to revised code 4731.22F to allow the addition of a consumer member into the supervision of investigations as drafted?
So moved.
Oh, goodness. Ms. Montgomery and I think Mr. Gandadakis? Yes, thank you so much. All in favor, aye?
Aye.
Aye.
Thank you. Any opposed? Okay, thanks, everyone. That concludes my report.
Thank you, Dr. Schoenstein. Ms. Montgomery, do you want to give the compliance committee report now, or do you want to delay that till the next board meeting?
I'll give them a brief report, and then we'll have a very brief meeting, as I think discussed right after. Or, well, I suppose at this point that would probably make sense. Just do a little brief meeting, and then we can fold everything into the next board meeting, next compliance meeting. We had we were bumped off of. We had some difficulties, so that we weren't able to complete our meeting in full, and only in part. We had basically three things to address. A follow-up where Kim has been very thorough. You'll recall last compliance meeting, we talked in the compliance committee and then brought forward to the board meeting a discussion about let's take a look at the costs on evaluations and see we believe in, having looked at it and staff look at it, that the efficacy of a 24-hour versus 72-hour inpatient, outpatient, evaluation is equal or substantially equal. And getting past that, is it good enough to do outpatient versus inpatient, as the reflected concerns that Dr. Rothermel had? Our next step was, if we can have the lower paid professions do an outpatient evaluation, we will perhaps be more fair with more people absolutely trying to address their problems. But the cost was so insurmountable in the lower paid professions that often we had people withdrawing their requests to be relicensed, etc., or make licensure. So that's where we were. We brought all of that to the board, but we didn't have any motion. So on our next board meeting, next compliance meeting, we will make a recommendation. Or we've already made the recommendation, but we'll review whatever proposal Kim wants to resubmit to us as to the language, and then ask that the board at the next board meeting adopt it. We then went into, we had the MAC letter, and the MAC letter essentially was concerned about language we were using on applications. This is when we got cut off, but generally speaking, we had conversations about look back, and basically reduced itself to, should there be a look back? Should it be, if so, is it 2 years? Should it be 5 years? And that's where we were sort of in the conversation. We had conversation about the kind of questions we were asking. And I raised a question about consistency. We asked this question on an application, but we don't ask it on, on a renewal, but we don't ask it on a first time application. So that needs to be leveled out a little bit. We'll bring our observations of that and recommendations to you as a board next board meeting. And finally, we were able to talk about a couple of legislative proposals we'd like to have wrapped into our medical board legislation. One is a proposal that, and again, we haven't voted on it in committee, but I suspect that we will get a positive vote that says, why not require our licensees to immediately report when there is a violation that they would ultimately have to report on their application or renewal application. And we also had a question raised that I think, again, not speaking for the committee, but I think we will also bring to the board a desire to have, as part of the medical board legislative passage, to see if we can exempt from public records those personal backgrounds on mental health and substance abuse answers, so that we still can get the information. If we all recommend a look back, and I think that will happen, but if we get a look back and we still can use that, but can we exempt it from being a question of public records? Because it's clear, and we did talk about this in the little time we had, that a lot of people aren't telling the truth. They're not disclosing. We find out from other folks, which is not a surprise. That doesn't mean we don't ask. It just means that when they don't tell us the truth, it's just yet another count on the citation list to them. So that's where we are. That's what you can expect to come forward to you at the board meeting next. And I think that's what we can expect in the next compliance meeting.
Thank you, Ms. Montgomery.
Dr. Bechtel, I'm sorry to interrupt. I had inserted a finance update for Dr. Schottenstein.
Okay.
So I just wanted to make sure we didn't miss that.
Yeah, Dr. Schottenstein, we'll let you go forward with that. Sorry about that.
Apologies for the interruption.
The money is
No worries, of course. Thanks, everybody. So looking at our fiscal update for January 2021, Revenue was $321,115. That is a significant dip in revenue from last month, and last month was a dip in revenue from the month before. So you may recall that there's another delay in the renewal deadline. We've talked about it, this time until July 1st. So the decrease in revenue is a function, once again, of our licensees delaying the renewal of their licenses. So the bad news is that our revenue is down. The good news is that it is very much expected and should likely be rectified as we approach the end of the fiscal year and our licensees start to renew again. You may note that our cash balance is substantially down from last month at $5,943,016, but that is still high by historical comparison, as 1 year ago our cash balance was approximately $5.2 million. So our cash balance should act as a cushion over the next few months with regard to the anticipated decrease in revenue because of the renewal deadline extension. And again, we should recoup that revenue from the deadline extension later in the fiscal year, just as we saw in November 2020 with the previous deadline extension. We have some 13,600 licensees, including 8,500 doctors, who were due to renew by April 1st, but took advantage of the licensure renewal deadline delay. That represents approximately $2.5 million in revenue. We are hopeful that our licensees will not all wait until July 30th to renew. So just like last time, as we heard, staff is going to send email communications to our licensees every 2 to 4 weeks until July 1st, encouraging everyone not to wait until the last minute. With regard to our spending, we only just received the invoice from DAS for the last 4 or 5 months of rent and various other services they provide. That was reflected in the January 2021 numbers as a spike in expenditures. The DAS total charge came to $229,000, and combined with an anticipated drop in revenue because of the licensure renewal deadline delay, this contributed to the negative impact on our cash balance, and it will going forward. We will have a similar issue for the February 2021 numbers because we just paid a $330,000 invoice for e-license services from DAS. That is a yearly charge and covers current services, and credit card processing fees continue to trickle in. The credit card vendor is consistently late with invoicing, and we have expressed our concerns about that. Payroll and other spending are otherwise pretty consistent. You may notice that we did not receive any fine revenue in January, but we did levy $59,000 in disciplinary fines. That includes 2 $18,000 fines assessed in the context of permanent revocations, so those will probably go to collections. And one licensee was assessed an $18,000 fine and has already paid it. On another note, we heard earlier that Stephanie testified before the House Finance Subcommittee on Health and Human Services regarding the State Medical Board budget as proposed in House Bill 110. And I did also view the testimony, and I thought it was great. And we heard about the controlling board approving Ms. Szymanski's increased limit on her contract, and so we're very glad of that as well. There's no new business. Any questions on Finance Committee matters? Okay, thanks, everybody. That concludes my report.
Thank you, Dr. Shenstein. Dr. Saffron, will you give the licensure committee report?
Thank you, Dr. Bechtel. Several items from the licensure committee. First, we had a very robust conversation and presentation from the executive director of the Interstate Medical License Compact. People asked a lot of questions. They had some concerns, and that discussion will continue. The next item was resumption of enforcement of continuing education CE requirements. The licensure committee voted to bring this to the board for their vote to resume the enforcement. So the motion I would ask for would be to approve resuming the enforcement of continuing education requirements.
So moved.
Second, somewhere? Second, Dr. Parzanowski. A voice vote is fine. All in favor?
Aye.
Aye.
Any opposed? Next item is Joe Turek, Deputy Director of Licensure, has put forth some revisions to proposed licensure application questions. We reviewed them in licensure and wanted to bring them forward for your approval for ongoing licensure applications. Joe is here to answer any questions that you have. Seeing the excitement of your questions, I would entertain a motion to approve the questions for the licensure application.
So moved, Dr. Johnson.
Dr. Johnson, a second, please.
Second, Dr. Cockrell.
Any discussion? I assume we can do a voice vote for this as well. All in favor?
Aye.
Aye.
Opposed? Wonderful. The last items are licensure considerations. We have 7 licensure requests. Information on each of the requests have been prepared by licensure staff and distributed to the board members. Does any board member wish to consider any of these applications separately? Okay. Do I hear a motion to approve the licensure staff recommendations for the requests of Marian Bachmeyer, Dr. Essen, Elizabeth Marchese, David Park, Girish Ragathon, I butchered that, I'm sorry, Linda Rowell, and Holly Ward. Is there a motion? So moved, Dr. Johnson. Second? Second, Dr. Rothermel. Any discussion, please? I believe we have to do a roll call vote.
Yeah. Dr. Rothermel?
Dr. Rothermel?
Yes.
Myself, Dr. Safran, yes. Mr. Jackalone?
Yes.
Dr. Soin?
Yes.
Dr. Schottenstein?
Yes.
Dr. Reddy?
Yes.
Dr. Johnson?
Yes.
Dr. Cacarella?
Yes.
Mr. Ganadakis?
Yes, sir.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
And Dr. Bechtel?
Yes.
I believe this concludes the licensure committee report. Thank you.
Thank you, Dr. Safran. Next on the agenda, please turn to the compliance section. And there's some reinstatement requests. Christopher Bashy is requesting a reinstatement. Do I hear a motion to approve the request for the reinstatement of the license of Christopher Bashy, MD, subjected to probationary terms and conditions as outlined in the August 14th, 2019 board order for a minimum of 5 years? Do I have a motion?
So moved, Dr. Johnson.
Second?
Second, Dr. Cockrell.
Thank you. We'll have a roll call vote. Dr. Rothermel?
Abstain.
Dr. Safran?
Abstain.
Mr. Gacaloni?
Yes.
Dr. Soin?
Yes.
Dr. Schottenstein?
Yes.
Dr. Reddy?
Yes.
Dr. Johnson?
Yes.
Dr. Cacarella?
Yes.
Mr. Ganadakis?
Yes.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
And myself, Dr. Bechtel, abstain. Now we'll go to the office conference review. Do I hear a motion to approve the compliance staff's reports of conferences for February 8th and 9th of 2021? Do I have a motion?
So moved, Dr. Cockrell.
Second?
Dr. Johnson.
Thank you. Thank you, Dr. Johnson. All in favor, say aye.
Aye.
Opposed? Okay. We do have before us now some probationary requests. At this time, we will consider the probationary requests in today's agenda that have been prepared by the Standards Review and Compliance staff and distributed to board members. These include Julie M. Anderson, DO, Susan Donna Lawrence, DO, Stephen Leon, MD, Brian Luce, MD, Colin S. Moorhead, MD, Ariana Noyoy, MD, James E. Palmersberger, PM, Vernon Reynolds, DO, Scott Weldon, MD, and Aubrey Winkler Kruger, PA. Before asking for a motion, does any board member wish to consider a probationary request separately? Seeing no request, do I hear a motion to approve the secretary and supervising members' recommendations on probationary requests? Do I have a motion?
So moved, Dr. Johnson.
Johnson, a second?
Second, Dr. Cockrell.
And we'll need to have a roll call. Dr. Rotherwell,
Abstain.
Dr. Safran,
Abstain.
Mr. Gacaloni,
Yes.
Dr. Spilling,
Yes.
Dr. Schottenstein,
Yes.
Dr. Reddy,
Yes.
Dr. Johnson,
Yes.
Dr. Coccarello,
Yes.
Mr. Ganadakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
and myself, Dr. Bechtel, abstain. Before we adjourn, I guess Ms. Montgomery will have the compliance link back into the compliance meeting right after this. I know we also have a medical marijuana meeting too. Stephanie, do you want to have us do that at maybe 1:50?
So we have the medical marijuana meeting currently scheduled for 2:00. So I thought we haven't had a break at 8. So I thought maybe we could finish up the compliance and then maybe take a 5-minute break and then start medical marijuana at 2:00.
Sounds very good. Thank you. And this concludes the March 10th, 2021 meeting of the State Medical Board of Ohio. Do I hear a motion to adjourn?
So moved.
Second?
Second, Dr. Cockrell.
So how are we getting?
And opposed? Okay. The meeting is now adjourned at 1:41.
We're keeping the lines open for the compliance folks. Just stay on.
Okay.
This conference is no longer being recorded.
Yes, that is true. I'll start the recording when the compliance committee resumes. We'll just call that an unannounced 3.5-hour recess. And whenever Ms. Montgomery, you're ready to start, just
I'm ready. I thought we might just do this in the next board meeting, but we'll just do it now and get through it.
We have to record, Benton. We have to record this.
yes, I will do that.
This conference will now be recorded.
Thank you.
Beautiful.
Okay, our agenda, we were talking, first of all, our agenda was to address the question about, we approved the minutes. Now we're looking at the OPHP evaluation discussion. You'll recall in our last meeting, we had a proposal by staff to say, we all agree that we should have a cheaper, that the more educated of our licensees should probably go with 72-hour, while our those with less educational requirements could do a 24-hour evaluation. The staff made a proposal about A and B groups. We presented that to the board. We didn't do any voting on it. Chris, Kim and her most efficient self, as always, and Kim, God bless you. You've done a wonderful job, has come to us with a proposal which we can either look at now or look at in the next compliance committee meeting, because it doesn't make any difference what we do now because we can't go back. We're not going to be going back into the board meeting. My suggestion is, Kim, why don't you just give us your proposed language and any memo that you might want to attach to it, and we can look at it at the next board meeting, unless the compliance committee wants to address it right now. If you want to address it right now, we'll do it right now.
May I ask a quick clarifying question about that? We heard from Dr. Rothermel before we broke that she thought that it made sense to have our outpatient for board ordered mirror our outpatient for One Bite. Please, Dr. Rothermel, correct me if I'm wrong. I think that it makes sense to probably bring this back to the compliance committee in light of that recommendation, because that's a pretty significant change that you should, I think, see in draft I like that change, but for the record, but that's up to you all to decide. But I think you should all look at that and draft before we take that.
And I also think it would help to, Kim, if you want to put together a little memo that talks about, we will always, as a board, have a right in the board orders or in the step 1 or step 2, do something other than, we're just trying to give the authority to do a 24-hour or 72-hour. But it may be, as Dr. Rothermel discussed, we have somebody in category B that, which is sort of all the other licensees except the docs and anesthesiologists, assistants, and PAs, we think needs to have a 72-hour evaluation. And I think that flexibility needs to be reflected in maybe your memo and whatever you give to us. Is that okay with everyone?
I do think, and so, I went back and looked at the rule, and I think that for the board ordered evaluation, for like what we have now for MTs, outpatient is a minimum, and 28 days inpatient is a minimum. And the rules do allow for a treatment provider based on clinical grounds to say that the treatment could be longer. So the treatment in the rules is a minimum for the board. For one bite, it's a lot more flexible. It just says it's based on an individualized treatment plan, and there's not a minimum for the treatment, if that makes sense. So I think what Dr. Rothermel was saying is if the treatment provider thought that individual needed to have longer, they should have longer. And I think the rule does allow for that, but it doesn't allow for not having a minimum. Does that make sense?
Yeah, I think you should put it in a memo though and give it to us and address that so that we're clear what we're voting on or as a recommendation to the board, and then the board is clear on voting.
All right. Very good.
Right. Unless the board wants otherwise. And on the MAC letters,
real fast, Ms. Montgomery, if I may.
Sorry, I'm sorry.
No, not at all. So I just wanted to say, Kim, and correct me if I'm wrong, please, but if that's the case, what you're saying about the minimum, then on some level, the language as drafted sort of accomplishes Dr. Rothermel's concern, right? In other words, we have that additional opinion now. It does not necessarily imply the need to change the language that you brought us today to satisfy Dr. Rothermel's concern. Do I have that right?
I think so, but I do think there's a little bit of a nuance that we probably should discuss and bring back, and that's, do you want a treatment minimum for board-ordered people when you don't have that for one bite? So I think that's a little bit of a nuance, but I think the way it is now, I think it does answer Dr. Rothermel's question.
Okay, thank you.
So if you take a look at it, because by definition, if you're in one bite, you already are in some kind of treatment. And that is a minimum, isn't it? You don't get to one bite unless you're in some kind of treatment.
That's not exactly right.
I can go into one bite and never get an evaluation.
So one bite itself is the evaluation process. And then if they choose to go into treatment, what frequently happens is they go to one bite, they decline the evaluation or treatment, and then they come back and we board order. So I just want to make sure people, and this was something it took me a while to understand, just because they're in the one bite process doesn't mean they're in treatment. They could be in the evaluation process, but then come back to us for board order treatment. Which is
so then Kim can address that to us to clarify. I'm sorry. Thank you for clarifying that. So if no other questions, move on to the MAC letter. The MAC letter, we were talking about, first of all, we're talking about, let me get the legislative stuff off the roll. We talked about, let's look at whether we can make questions about substance abuse and mental health issues exempt from public records. And we talked about a legislative proposal where we will add that there must be an immediate duty to report our licensees on those issues, which would trigger some kind of review or discipline. We talked about that. I don't think there's a debate about that. Then we talked about what is the look back? Should we have a look back at all? If we have a look back, what is the length of time? So what is the committee's? What do you think? Yes, Dr. Schottenstein.
Hi, thanks. So, it was several years ago that we shortened the look back from 10 years to 5. And so, the thought being that it's not productive and on some level not fair to licensees, both things being true, to have such a long look back. And so that's really more of the issue today. In other words, in the same way that we moved from 10 to 5, excuse me, are we right to move from 5 to 2? And so, personally speaking, that feels comfortable for me. I think that it's important that emphasis as much as possible be on, behavior and not diagnosis. And I think the closer we get to current status, the closer we are to emphasis being on behavior and not diagnosis. Very respectful of, alternative opinion, but that would be my 2 cents, is that we'd go to 2 years.
Mr. Jack Maloney.
Well,
go ahead, Bob.
This is one time I'm going to disagree with Michael. Again, here's my 2 cents. I hate to ramp it back because now it starts to look like we're in it for the licensees and not the public when you move from 5 to 2. Secondly, historically, 10 is way out there. I would agree with you. And that's why we ramped it back to 5. But 5, there could be a pattern there that, isn't evident in 2. And we missed that because the 2-year window doesn't give you enough room. So my concern is there's something going on. We only see the last 2 years, and then, we don't know what's going on before that. And also in terms of, discipline, if we're moving it to 2, well, you've lost 3 years on the discipline if they're been ducking and dodging you the other ones. My concern is I'd rather have the early warning as opposed to the late warning. And I understand it's mental health and those other things, but I guess, as a public member, I want my physician to be on the money, just like I want my lawyer to be on the money when it comes to my personal well-being. So I'm a little bit in the other camp.
Any other questions? Any other comments? If not, I would have to agree, and no surprise to you, I would have to agree with you, Bob. I would want to be able to have 5 years for the pattern. If you remember Dr. Martinez on our agenda today, as they started looking back, we went back in this instance because of the investigation, went back to 93, and they started seeing a pattern that they did not see in 18 until he had a psych exam in 18. And then in the psych exam, he acknowledged that he had an evaluation done in 07. And in 07, he acknowledged that he had had a series of sexual and abuse, drug abuse stuff. So it seems to me we can't, for the consumer, we need the look back period to be 5 years. And that's just my opinion. That's Bob's opinion. But what does the rest of the board, what does the rest of the committee think or the board think? That's on. Dr. Coccarella, do you have an opinion on that?
Yeah, I think 5 is probably a happy medium. We ramped it down before, and I agree with Jacqueline, that we're at the risk of probably going a little, swinging the pendulum too far the other way, and then we might be revisiting this in 2 years or whatever time period that is, and saying, well, let's go back to 5 years. So I'd keep it at 5.
Dr. Rothermel?
Well, I think the FSMB is certainly recommending 2 or even just current, which I would be much more comfortable with 2 years. I'm not sure we really get more data in the 5 than we will with the 2 as far as significant data that we will use in order to make decisions. And I think that a lot of states have already gone to 2, and obviously, I think at least through the FSMB, there haven't been reported problems. So I'm comfortable staying at 5. I think we're going to be moving it to 2 if we give this more time at 5. I think we'll probably look at this again in the not too distant future, just from the standpoint of, are we really benefiting from this? So I would vote for 2, I guess, if I were voting between 2 and 5 today, but I'm comfortable either way.
And Dr. Safran?
I agree with Dr. Rothermel in the sense that either one would be okay. The issue is that I don't necessarily have an expertise in mental disorders, although many of my patients may already have that. But Dr. Schottenstein is really the expert to rely on, I feel, in this board. And I think that if he's leaning towards 2 years of giving you're getting the right picture, you're seeing the right things in a 2-year period, I would probably go with the 2 years. But again, you really can't go wrong with the 5 years. But I think that if he feels that the picture that we get would be adequate, then I think the 2 years would be fine.
Dr. Schottenstein and then Dr. Bechtel.
So, Dr. Safran, you're very kind to say that, but I really don't want my area of practice to be determinative. I think that the question is really more, how productive is it to have years 3 through 5 versus the impact on the licensees, right? And so if there was a clear benefit on having years 3 through 5 information, I think that we'd be right to have it. I think that the concern is by going back too far, and I'm not saying 5 years is too far, but the concern by going back too far is essentially that it simply becomes punitive, right? Essentially what we are trying to ascertain is whether or not somebody is impaired from being able to practice. Would we determine that someone is unable to practice based on something that was going on, 3 to 5 years ago in the absence of anything going on in the prior 2 years, right? So that's just sort of, my thought is that I would, emphasize, behavior over diagnosis in a current fashion in that regard.
So, Dr. Bechtel's left here, but Dr. Safran?
My only point was that you see this and you see the relevant issues here, that 2 years would give you a picture that would be enough. And that's all I'm saying. I mean, you're treating that, you're seeing that, and you don't see any gain with years 3 to 5.
Well, if I were treating somebody, I would want a long look back. If I'm assessing whether or not somebody is appropriate for licensure, then the question is that 2-year look back sufficient? Again, we asked ourselves the same question when we went from 10 to 5. At some point we said to ourselves, what does it gain us to have the extra years 6 through 10? and we shortened it up to 5, which I thought was justifiable. And so I'm simply applying the same model and saying, and again, because I'm also respectful of consensus, that it's, the FSMB, recommendation at this point to move in that direction, I'm sensitive to that as well. And so, in that regard, I feel like 2 is fair, but I'm very respectful of people having the thought that we'd be right to leave it at 5.
So can I weigh in for just a moment? I think that I understand predictive or productive question that you've asked, Dr. Schottenstein. I'm looking at predictive and preventable and protection. And I think as a consumer member, I realize your point of view is through the licensee and ours is not. And I just think that it is not that much of a burden, particularly if we have the ability to keep these exempt from public records, but it's not that much of a burden versus the potential of protection, even in the kind of cases that we looked at today, that gives us a sense of that there's an issue that we should be addressing. And so I feel pretty strongly about the fact that we should not at this point, not that we wouldn't be open later to look about it, but it just seems to me we protect the public more with a 5-year. In fact, Dr. Bechtel, we didn't get a chance to ask you.
I think right now I feel comfortable with the 5 years. I think that with the FSMB, I think the trend will be moving towards 2 years eventually. But I think at this point in time, I would feel comfortable with a 5-year look back.
So we are at 2:00 for our medical marijuana meeting is starting at 2:00. I would recommend that our impairment and mental health questions need a revision anyway. They're very clunky. Ms. Montgomery, I think you and I talked about that. They're very confusing for the reader. I would recommend that we come back to you with some revisions to those questions, hearing that there's consensus on the 5-year and bring those back to you for the next compliance committee for review.
Because we in cleaning up the language was the next question is cleaning up our language,
Yes.
because it's very hard. We've talked about it. It's kind of hard to understand. That means that we are not going to be getting to, Brandy, we're not going to get to your compliance stats. You worked very hard on that. And we'll just talk about it next board meeting, if that's all right, next committee meeting, if that's all right with you.
Yeah, those were just an update. So only discussion would be if anybody had any questions. Other than that, they were just an update. So thank you.
Thank you all. And I think we'll just entertain a motion to adjourn. Bob, Michael, thank you. Second, Bob, and then I cut you off before we say we're adjourned. Is it okay? All right, adjourn. Bless you. We'll see you next month. For those of us who are not on the next committee meeting. Thank you.
This conference is no longer being recorded.
Thank you.